Hi, everyone. We are going to record respiratory. So give me a moment to share the screen and get up Elizabeth's PowerPoint for respiratory. You do have in your, oops, wrong one. You do have in your packet your guidelines for bronchiolitis. And we are good to go.
All right. Good morning again from Lester. And I hope you all are either in your pajamas or comfy clothes.
At least no makeup.
At least no makeup, like Dr. Blankenship and I, we were both talking about. It's like, yeah, I got a shower this morning, but no makeup unless that happens to. There's no makeup going to happen until I go back to work. So I hope all of you all are well, by the way. Oh, and I want to say congratulations to Caitlin. And I know you all already know that she's had her baby, but Charlie's absolutely adorable. So congratulations, Caitlin. And I hope you and baby, you're doing well. So we're going to talk about respiratory. And that's the interesting thing in that I just talked about ears, and that's so much of what we do. And in pediatrics, respiratory is probably that, and throats are another significant part of what we do. What you don't know is, since that didn't take, last week when I was taping these lectures, I had just been diagnosed with strep throat, and I was so we were really careful. Not only were we social distancing and cleaning off everything as we went, I was really trying to distance from Dr. Blankenship because I didn't want to give her strep. So it's been 20 years since I've had strep throat. I've been an NP for 15, and somehow I have avoided strep and flu all these years, and somehow it got me this time. So I am much better this week. It does get kind of dry, so I have to stop every once in a while and take a drink. So respiratory, and as we started with ears, we're going to start with anatomy. You all know this well. This is Anatomy 101. The upper respiratory tract includes the nostrils, the nasopharynx, the larynx, the upper trachea, the eustachian tubes, and the sinuses. Okay? So, and our lower respiratory tract involves the trachea, the bronchi, and the lungs, of course. And we know that the left has 2 and the right has 3. And on the left, where that third, because of the heart, where that third lobe would have been, we have this place called the lingula. Okay, so, and we know that the bronchi on the right is shorter and wider than the bronchus on the left. So we're going to talk about this a little bit more later, but that has a tendency to be foreign bodies with kids that swallow or go down the windpipe. That's where it has a tendency to lodge. And as we divide out from the bronchi, we get the bronchioles and the alveoli, which will become significant as we talk about lower respiratory tract infections in kids. So your common URI, upper respiratory tract infection, i.e. the common cold. If you were to walk into, especially here for us, the Med Center ED, and have upper respiratory type symptoms, they would do a strep test on you probably, but they would also do a respiratory panel on you. What is wonderful about this because it tests for several different things. It tests for rhinovirus, adenovirus, metapneumovirus, coronavirus, 3 different types of coronavirus before we had COVID-19. But we have had coronavirus around for a long time. Well, let's see. There's RSV and flu A and B. So it's all included in that respiratory panel, and they get that back the same, it's not as quick as a quick strep or a quick flu, but they do get it back in a very short period of time, and they're able to diagnose for sure and for certain whether you've got a viral infection, whether it's treatable or not. So that's a really good thing. I am hoping that soon in primary care, we get that same test, and where you're working, you may have that, but very common in your practices, especially in most pediatric offices, you're going to have the quick test for flu and strep. Okay, so how do you know whether this kid has strep or not? How do you know if this kid has RSV, the flu, cold? So a lot of people will tell you that you can tell by looking at their throat if they've got strep throat. Well, I'm here to tell you that there are some presentations of strep that are classic and some that are not. I've had kids with normal looking throats and no fever be positive for strep. And I've had kids with the most awful looking throats with white exudate on their tonsils and fever in the whole 9 yards and be negative for strep and a throat culture be negative. So you can't just diagnose strep based on visual inspection and exam. Okay. So when we start talking about the common cold, we've got a gradual onset, starts with rhinorrhea, it usually starts clear. They may have some sore throat or some difficulty swallowing, i.e. that's where you need, if they ever say sore throat or trouble swallowing, then you probably need to test them for strep. Can they have a cold and strep together? Sure they can. They may all have a mild cough. They may not be sleeping well due to the cough or the runny nose. They may have a low-grade fever. Anything in peds that's under 102.5 is considered a low-grade fever. Parents don't consider 102.5 a low-grade fever, but we do in peds. Now, the interesting thing is the common cold can lead to thicker and more purulent nasal drainage. And we live in the Ohio Valley here in the state of Kentucky. And colds that go into thick green nasal drainage usually need to be treated because not only does it go into thick green nasal drainage or the green snots, it usually goes into ears and it can go into other things. So we treat green snot in our office, especially if it's been there for a while. Because these kids they're in school, they're training these germs back and forth, they're just not going to get any better. So on your basic exam, your bilateral breath stands are usually clear to auscultation. You may have some mild injection in the conjunctiva, maybe not. Your nasal mucosa, how many of you, hold up your hands, and Caitlin Gary better hold up her hand. How many of you look in noses when you do an exam? Oh, Dr. Blankenship says she looks in noses. There's very few of us that actually look in noses during our exam. I've had lots of kids that I've seen who see other providers on a regular basis look at me and say, I've never had anybody look in my nose before. I said, well, if you're going to be with me, I'm going to look in your nose. Well, that's gross. Well, it's like, I don't care. We're going to look in your nose. So if you look at a nose and you see swollen inferior turbinates, and they're red, that's usually probably a viral process going on. Now, if they're pale and boggy, that's usually an allergy response. Pale boggy turbinates, usually, and clear mucus. So if you've got those red and inflamed, though, inferior turbinates, and you've got the yellow-green stuff in their nose, so the next place I'm going to look is I'm going to look in their oropharynx. And you may have some generalized redness in that oropharynx. A lot of times people call it postnasal drip, but it's that green goo draining down the back of their throat, and it's thick and it's yucky. And sometimes it's in the early stages. It may be yellow and white, but it's causing them significant discomfort and problems. So they also may have some mild, shoddy cervical nodes, usually less than 2 centimeters. I call it 2 centimeters. All right, that is a 1+. If it's the width of my finger, to me, that's a 1+. That's about a 2+. Inch is 2.5 centimeters. So kind of look at your fingers, measure them. If I can feel that and it's just about the size of my finger, I call that a shoddy, non-tender lymph node. If it's bigger than that, if it's tender, then that gets my documentation up a little bit more. So we're going to do a strep and a throat culture. We always follow up strep with throat cultures in our office for a reason, because sometimes kids will have not group A strep, and the strep test is very specific for group A beta hemolytic strep. So you can have a quick strep that's negative, okay? And this kid looks like strep, smells like strep, acts like strep, but you have a negative test. Usually I'm going to treat them anyway. But then the throat culture comes back the next day, and it can either they did a really bad job on the quick strep, and when they've grown it on culture overnight, then it shows up, or it's not a group A strep. So it's always important to follow up a quick strep with a throat culture. Okay, just do them at the same time, get those swabs done, and then and so you have it. So if they're positive for strep, they're not going to run the throat culture. Okay, So at least not in our building. In our practice, they don't, because we've gotten the test. We've verified that we've got strep. So just food for thought. All right, so when we talk about treating a viral upper respiratory infections, and these are some basics on this page that we use every day. And we use it for lots of different respiratory infections. So these, you might even want to print up some basic cold / upper respiratory kind of guidelines to give to your parents, because they have a tendency to forget things. So some of our basics is fluids. Push, 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 push. The more fluids you give them, the thinner those secretions are going to be, and it thins and moistens those mucous membranes. Dr. Blankenship, I've got a question. I moved this actual, where I'm seeing me up in the corner. Is that a problem? Does it reduce what they see?
No, they can be looking at theirs.
All right, give us just a second.
That's,
it was in my way.
oh, no, that's perfectly fine.
All right, so we're good. All right, just had to clarify there for a second. So fluids, fluids, fluids. Push, 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 push. Sometimes I look at parents and say, I don't care if they're eating, as long as they're drinking and they're peeing, but the more fluid we can get in them, the thinner those secretions are going to be. Humidification, not a steam. We want a cool mist humidifier. We want water only. Okay. Parents ask me, so I've got one of those Vicks. It's like, oh, that's great. Just put the water in it. Oh, you want me to put the Vicks in it? No, Vicks is good, but we just want the water because we want to humidify the nasal passages and the nasal pharynx, because these kids are mouth breathing and they need as much humidification as they can. Now, really important to remind parents of the importance of keeping those cool mist humidifiers clean, because they themselves, you can't just keep adding water to them, because bacteria will start growing. Then you start spraying bacterial out in the air all the time. So it's really important to keep those clean. And then the other part of that is, what are we going to do to this nose? Saline, 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 which is at the bottom. Frequent and copious amounts, and then nasal suctioning with bulb syringe. And be careful, and you've got to be gentle with the nasal, and you got to teach your parents this. I personally prefer the nose Frida. If you don't know what the nose Frida is, there's a commercial for something where the dad is using a nose Frida to suck out his baby's nose in the middle of the night, and says, if you're willing to suck snot out at 3 a.m., then blah, 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 blah. I can't remember. Keep thinking I'm going to remember what that is, but I see it and I laugh every time. The nose Fridas are great because you can use your mouth to apply the suction. It can be gentle. It can be prolonged. There is a filter to keep the snot from coming up, or any of the nasal secretions from coming into your mouth, and you can change out the filter. But the nose Fridas are really good. And the end of the nose Frida is blunted, and so it only allows so far to go up into the nose. The bulb syringes that you got at the hospital when babies are born they're rubber, they're great, and they have a long, narrow tip, so you can really go up in there, and you think you're doing a really good job. So you've compressed the air in that, and you stick it up that baby's nose, and you suck out that goo. Well, okay, if you get to happen to trap that against the side of a nose, and you're making hickeys on the inside of the nasal passage, or you're irritating the inside of that nasal passage to the point that the nose can bleed, and it also causes irritation. And when you irritate tissue, what happens? You get inflammation, so the nose swells, and you get tissue damage. So you want to prevent that. You need to teach parents that if you're using a bulb syringe, it doesn't need to go any farther than right at the opening of the nair. Okay. Now, NeilMed just happened to be, I'm not promoting NeilMed, but NeilMed I know happens to make another type of bulb syringe that are silicone, and they're clear, and you can pop off the end that has the rounded tip on it, and you can also open the other end, and you can wash these babies out, and you can dry them out much better, because the ones that you get from the hospital, the old blue or the red ones, they have a tendency to grow bacteria. You can swish them in bleach water all you want to and suck that bleach water in and out, but the problem is you can't dry those puppies out. So they have a tendency to grow bacteria. So if you've ever cut one of those open and looked at, as gross and disgusting. It's like, oh my God, I was doing that to my baby. So, saline, suction, suction, suction. As far as the saline, it doesn't matter. You can use generic. There's some made for babies, the ones for adults. It's all salt water, and it's isotonic, so you're not hurting your child. And when I was working, I graduated from UK, and I was working for UK for a while when I first got out of school, and we had a lot of RSV babies come to the hospital. It was one of the most common things, and we're going to talk about RSV down the road, that they hospitalized children for, especially in the winter, especially acute on the floor. And their standard treatment, while they were maintaining oxygen sats, were every hour, the parent was to put 10 drops of saline in each side of the nose and then to suction it out every hour. So, because parents will say, well, can I do too much? Well, no, you can't do it too much. And then I tell them that story. And so they feel better about it. It's like, this is just salt water. You cannot do too much salt water. I always recommend also, if the baby's having trouble breathing and they're having trouble eating, especially if they're taking a bottle or nursing, that you do it about 5 minutes or 10 minutes before time for the feed, so you get that nose cleared out really good, so that baby is not as congested and does a better job with feeding. And sometimes when a baby's got a URI, and they may take smaller feeds more frequently, so you may have to adapt the feeding schedule, and you may have to tell parents that they need to adapt their feeding schedule because the baby just can't breathe and they just get worn out trying to, that suck, swallow, breathe cycle just gets really hard. Or you may have to take a pause and suction them out and wait and then start again. So that's a part of your teaching. And when we talk about treating an upper respiratory infection. So let's talk about sinuses. Sinusitis is another commonly diagnosed upper respiratory kind of thing. We've got our frontal sinuses, our sphenoid, our ethmoid, and of course our wonderful nasal septum, and our maxillary. So one side shows you healthy, one side shows you inflamed. Now, the interesting part is that maxillary sinuses, they are present at the second trimester, but they are not fully pneumatized until about 4 years of age. So if you're doing, also, if I've got a kid who's got green spots, I am touching their face, okay? I'm feeling, especially older kids, I'm feeling that if there's any tenderness or pressure. Now, there's really no need for me to touch right here much if they're under 4, because they don't have, they're not functioning, okay? Now you got your ethmoid sinuses. They develop around the fourth month gestation, and they are pneumatized at birth. Of course, they're right here in the nose. As soon as they start taking breaths, those are pneumatized. The sphenoid, they start to form the first couple of years of life, but they are not really fully developed until around 6. So do you get where I'm going with all this? The sphenoid doesn't reach a full adult size till by age 12. So, and then the frontal up here. So, you can't diagnose a sinus infection in a little kid, especially here or here, if they're under 4 years old. They may have green snot, but doubtful that they have a sinus infection. So be cognizant of that. We don't use, neither one of the docs that I work with very rarely actually diagnose sinusitis, and it's usually in our older kids, and we're going to talk about that in just a little bit. So as you see down here, these are your clinically significant sites of infection. So maxillary and ethmoid, and that's early to late infancy. And again, you may have some green snot, but you're not going to have a sinus infection, okay? Sphenoid, 3 to 4 years of age, and frontal, 6 to 10. So your school-age kid may have a sinus infection, but not your little ones. Usually have 2 different types of presentations with the sinusitis. If they've got the green snots and a high fever, that needs to be on your first list of differentials, is a sinus infection. Then the other presentation is a double syncoping. They may have had URI and got better, and now they're experiencing worsening symptoms. So some of the things we're going to look for, your major criteria are facial pain, fullness, and then thick green drainage or a green postnatal, a thick yellow green postnasal drip. Again, these are in your older kids because they're going to be able to tell you that your face hurts. This was me last Monday before I got a positive strep test. My face was killing me. So I think I had a sinus infection as well as strep. And that's what I thought I had. But anyway, moving on. So your minor criteria could be a headache, fever, fatigue, bad breath, sinus breath, dental pain. A lot of times if your ears are hurting or your sinuses are hurting, it may cause referred pain down into the mouth, a cough, and of course ear pain or pressure. What are we going to do for sinusitis? Amoxicillin is our first line, anywhere from 45 to 50 mg per kg per day in 2 divided doses, or our 80 to 90 mg per kg per day in 2 divided doses with a maximum of 1,000 milligrams per dose, i.e. a maximum of 1,000 or 2,000 milligrams per 24 hours. So when we talked about, if you've already listened to the ear, you'll know that I talked about make sure you know what your maximum dosages of your antibiotics are for a child, okay? And if this is a teenager, that's probably what are your adult, because a lot of, use your Hippocrates. I use Lexicomp. I have a book. My book is this thick. Caitlin will testify to that. I'm a book girl. And so if I'm uncertain about a medication, I look it up. So if you're concerned that this is, if you figured up your dosage and this is a lot of medicine, look up to what your normals, what your maximum dose is per dose or per day, okay? Especially in kids. It's really important. Amoxiclav is, even though amoxicillin is your first line, amoxiclav is great. So if you've got kids who are coming in that are frequent flyers, that have antibiotics frequently, or if they're in daycare, or if they have that moderate to severe disease and their face just hurts and they're older, you can do amoxiclav in 80 to 90 mg per kg per day in 2 divided doses with a max dose of 2 grams per dose. Now, the interesting part about amoxiclav, it comes in several dosage sizes. And what's great is amoxiclav comes in a 600 milligrams per teaspoon dosage. And a lot of times with our older kids who can't take that pill yet, that've got a sinus infection and we're wanting to do a higher dose, we'll use that 600 per 5 dosage form. It has less side effects than your other dosages, and it gets what we need to do. Amoxiclav is great on a sinus infection. Now, if you've got kids that are vomiting with this, you may want to give them Resp at 50 mg per kg for a one-time dose. And again, if our kids are allergic to penicillin, do not give them Keflex for sinusitis. If you also notice when I talked about the ears, I also didn't say a word about azithromycin for ears. Azithromycin is usually 99.9 not very effective for ears. There's other options if they're allergic to amoxicillin, if they're allergic to the cephalosporins, if they can't take Clinda, if they fail Clinda, we've got Claret. There's other things, but azithromycin is not going to usually help with ears. So don't give it, okay? Now, sinusitis, we'll use Azith a lot with that green snot. A lot of times, especially with kids, especially if they've just been on amoxicillin. But if we've got a kid that we really think has a bad sinusitis and they're allergic to penicillin, we will use that 3rd generation cephalosporin so we don't have cross reactivity, and that's Ceftonir or Omnicef, and that's at 14 mg per kg per day in 1 or 2 divided doses. Now the next kind of couple of things are, it's in your book, and this chapter is chapter 32. It's on respiratory disorders, and it's written by Rita Marie John. And again, I have got to meet and gotten to know, she probably doesn't remember me from Adam, but that's okay. She is a well-known, nationally recognized PNP nursing instructor. She's at, I think, Rochester University. I'm not sure. Don't quote me on that. She's up north somewhere. She's an amazing teacher. So she has written this chapter on respiratory diseases. And again, it's another one of those good ones. If you going to read a chapter, this is one to read from front to back. So we're going to talk about diphtheria. Now, you don't see diphtheria. We haven't seen a case of diphtheria since 2003 in the United States. However, you need to be able to kind of look at this picture on the left. That is diphtheria. And then the picture on the right is exudative tonsillitis. That may or may not be strep, but that looks bad. I'm going to treat that, whether they've got a positive strep test or not. I'm going to treat it like strep. But what if that is negative and this kid feels bad and stays bad and doesn't seem to be getting better? We're going to talk about that, okay? Because other conditions can look like that. That's not always strep. Okay, so back to diphtheria. Diphtheria is very rare. Diphtheria protection against diphtheria is in our diphtheria, tetanus, and pertussis vaccine, or DTaP. But with all our anti-vaxxers in the world that think they don't need this, as herd immunity drops, we may see a rise in diphtheria. So be cognizant of it, even though we haven't seen a case of it in the United States since 2003. When I was working in Eastern Kentucky in Moorhead, I worked for a nurse practitioner that thought she had a lady with diphtheria. She tested her for it. She didn't. But she thought she had this grayish thing in her throat. So it's very highly contagious. It requires hospitalization. This is as contagious or more contagious than COVID-19. So if you ever see this, this is like, stop, emergent, get this person to the hospital, call 911. Get the ambulance to the office. And they're going to put them in quarantine immediately. So usually it starts out with a low-grade fever, this gray pseudomembrane, bloody nasal drainage can be a part of that, sore throat, hoarseness, cough, skin lesions, neck swelling, and lymphadenitis. Some of these things can be very common with other issues. They may have ear or eye infections with it. It does produce a toxin that can cause myocarditis, EKG changes, peripheral neuritis, so fingertips, local neuropathies, respiratory compromise, and cranial nerve damage. So diphtheria is significant. And again, we just need to be cognizant of these kinds of things in our communities where we have low immunizations. So now, pertussis, the other part of the DTaP vaccine that has to do with respiratory, is rearing its ugly head. If you've had a baby recently or been involved with somebody, they made sure that you've had an up-to-date Tdap, tetanus, diphtheria, and a cellular pertussis. Before they made pertussis acellular, even in vaccines, it used to cause a lot of local reactions and actually some pretty intense reactions. So when I was actually working in peds as a supervisor, when we went from straight DTP to DTaP, and the amount of localized skin reactions and post-shot reactions that we had with the really bad fevers and things dropped significantly. So a cellular pertussis is a good thing, but what they have found over the years is that your immunity, it just doesn't continue the type of immunity. So as they developed the Tdap vaccine, now everybody gets it. When it first came out, that only certain groups got the Tdap. Even your older people got just a TD when they got a tetanus booster, like in your 60s and so. So through all this, they've now just gone straight to Tdap, unless you're highly allergic to pertussis for some reason. Now, pertussis is very characteristic with a whoop or whoop style cough. This YouTube link goes straight to a whooping cough. If you ever hear it, you will know it on sight. Now, pertussis is kind of one of those things that it stages. So the first couple of weeks, you may have a mild cough. You can have some chorea or runny nose, sneezing, and low-grade fever, i.e. you have a URI. But as that passes and progresses to the next stage, we get to the paroxysmal stage. And this is where that distinctive cough comes in, that rapid firing. This can lead to vomiting. These kids get exhausted. Because if you've ever had a pneumonia or somewhere where you were coughing all the time, or an asthmatic attack or something, that because you get so sore, your abdominal muscles get so sore from coughing. And with these kids, vomiting is very common because it just puts so much pressure on the abdomen that anything's in their stomach is going to come up. So this is very distinctive. And so true story, was working with not the docs I work with now, but with another doc here in town, and they got a call that they had an Amish family coming in and pretty much thought that the kid had whooping cough. So as soon as they came in the door, they didn't leave him in the lobby. They brought him straight and put him in a room. And the kid was coughing when she came in and continued to cough the whole time she was there. It was pretty distinctive. And of course, we have to do the testing for this is a Bordetella pertussis swab. I think it's a swab. It may be a blood test. I can't remember, but I want to say it was a swab. And of course, it takes a couple for it to come back. And but we had that on board. We contacted our lab and we made sure we knew what we had the right stuff there to test with as soon as she got there. And so they tested her, and then we sent her home. And the convalescence from pertussis can from 3 weeks to 6 months, and the symptoms just wane over time. So now it's a swab. Dr. Blankenship is checking my and I am correct, it is a nasal swab, but it's a very specific nasal swab. It's a Bordetella pertussis nasal swab. So your office may not have those routinely. So you may have to contact your local hospital or LabCorp or Quest or whoever is your lab people to make sure that you've got 1 or 2 that are not expired around, especially if you work or practicing in a rural area, especially with a high non-vaxxed or non-immunized group. The interesting part is now if you have a baby, moms, their Tdaps are caught up, and anybody that's going to be around the baby, because what we were finding was infants who hadn't even started their vaccine series were coming down with pertussis. So before 2 months of age. Well, where are they getting it? They're getting it from parents whose immunity has waned over the years, parents, grandparents. So one of the new things that they're doing is making sure that everybody's up to date on their Tdaps, but before a baby goes home. Now, the treatment for pertussis is pretty simple. It's azithromycin. So in our ages of 1 to 6 months, they're going to do 10 mg per kg per day for 5 days. If they're over 6 months, they're going to do 10 mg per kg per day on day 1, and then 5 mg per kg per day on days 2 through 4, which is basically as I tell parents, is a Z-Pack for kids based on their weight. So it's liquid azith, but it's based on their weight. And it comes in 100 per 5, and it comes in 200 per 5. And so getting those 5 mg per kg doses, sometimes it's 1 point something milliliters per day. It can be really small amounts. So don't be afraid of that. You may have to write that specific 3.8 and 1 point something, 1.6, so do it. And they're used to it because that's what we do all the time. Another treatment for that is clarithromycin, which we all know is Bioxin. So that's 15 mg per kg per day divided over 2 doses for 7 to 14 days. Now, again, there's your max, 1 gram per day. And then good old-fashioned erythromycin, we can do that in our greater than 1 month of age at 10 mg per kg per dose, but it's 4 times a day. So if you had to choose between erythromycin and zithromycin, which are both macrolides and they're in the same family, which one are you going to do? You're going to do 4 times a day, or are you going to do once a day? Well, if you want compliance, then that's an easy choice. So we don't use erythromycin much just because of the compliance issue. So it's going to be really important to remember that you've got to prophylax close contacts to the person with pertussis, especially in the first 21 days after exposure with azith. And that means everybody in your office too. So if they have come through, anybody that they've been around, your RMA, your nurse, any of the reception staff, God love if they sat in the lobby and didn't know that they had pertussis or questioned that they had pertussis, you've exposed everybody in the lobby to it. So again, most of the time everybody's up to date, but if you've got kids that are immunocompromised due to cancer or where they've had a transplant and are immunosuppressed drugs, so those are important things to know. But pertussis is reared its ugly head back, and it's gracious and growing and well in our environment. Another thing we see commonly in kids, especially through the winter, is laryngeal tracheitis, otherwise known as croup. And this is an acute inflammatory disease of the larynx and trachea and the upper bronchi, and it gets that brassy seal-like bark. They may have some stridor on inspiratory or with cough, and they get hoarse, and sometimes they can have respiratory distress and sometimes they don't. Remember, so when you're looking at the x-rays at the bottom, you see the classic steeple sign. That is classic for croup. So look at that, and you can see in both of those x-rays, from the lateral and from the anterior posterior, that the trachea has narrowed. Okay, so it's inflamed. So it's got a very narrow pathway for air to come through. So i.e., so this can be some of your respiratory distress. A lot of times this is common in children under 6, but we've also seen it in older kids, especially if they've got younger siblings at home. Again, it is a viral infection, so antibiotics are not going to touch this unless there is a secondary infection. If it gets worse, they call it laryngotracheal bronchitis, and that's usually associated with a bacterial infection. This can last, that can last anywhere from 5 to 7 days. So how do we treat croup? Of course, we go back to that humidified air. We want that cool mist humidifier going. Sometimes cool air can be helpful. Occasionally vomiting can relieve the bronchospasm. Back a century or so ago, they gave Epicac, syrup of Epicac, for somebody with croup, so they would throw up, and that would help with any, if they were coughing, they couldn't get them stopped, they'd give them syrup of Epicac, and that would help reduce the inflammation. Corticosteroids, dexamethasone is our drug of choice. We're going to give either PO or IM 0.6 mg per kg in a one-time dose. Excuse me. Or we can also give, if they've got a nebulizer at home, if they're used, if they're wheezers or known asthma, sometimes Pulmicort or nebulized budesonide will also, twice a day, will usually help with croup. I have done the 0.6 mg per kg IM a lot. The very first time I did it, when I was working in Eastern Kentucky, it was with a baby that had really bad croup, and the mom looked at me and she said, "You're going to get rid of this with a shot?" I was like, "Yeah." "Okay. Is there a problem with that?" "No." I said, "If he's not better by tomorrow, come back and see me." Well, she calls me back the next day and says it was amazing by the time they got home, and he was so much better. So it really helps with croup. Again, antibiotics are not going to touch this viral infection, but remember, it is an inflammation of the upper airway. So we're not going to do nebulized epi in the primary care setting. Sometimes albuterol helps if they've got known history. Most of the time it doesn't, because we do albuterol because it is a bronchodilator. It's not going to help the trachea any. But sometimes with those kids with known issues, sometimes it helps, sometimes it doesn't. Cold medicines are not helpful. As I just said, bronchodilators are not usually helpful. If your O2 sats are falling with kids with croup, sometimes oxygen can help, but those kids are probably going to end up in the hospital if they're having to have oxygen. Heliox for severe croup, again, you're not going to be doing that in the office. That's going to be something that's going to be done in an acute care setting beyond your scope of practice. Table 32.4 in your chapter is really good, so review it. All right, moving on. So epiglottitis is distinguished from croup in that this is a pediatric emergency. This is a sudden onset of fever, sore throat, and drooling because they can't swallow. They are having difficulty breathing and they are toxic looking. And if you ever see a kid with epiglottitis, you will not forget it. They will tripod. Think about your toddler. They will tripod because they are doing everything they can to extend their neck, their arms, their trunk. They're doing everything they can. You know, they'll jut their chin forward, just trying to get in as much air as they can. They are scared absolutely to death because they can't breathe. So you'll see on the x-rays, the thumb sign, which is classic for epiglottitis. So you see the normal on the right, and then you see the swollen epiglottis on the left that is constricting the airway. These kids are sick. This is emergent. Call 911, get an ambulance, get some oxygen on them. It may or may not be helping, but better than nothing. Start running, you know, even if you're just nebulizing salt water, something to get some moisture in there to try to help them breathe until you can get, and just be prepared in case they quit breathing on you. So, all right. Now, one of the things you're more commonly going to see is bronchiolitis, not bronchitis, but bronchiolitis. And this causes inflammation and necrosis of the epithelial cells in the lining of the small airways, as well as copious mucus production. When you've seen RSV, you will recognize it. This is a URI on steroids, okay? It might even start as upper respiratory symptoms and it will progress to lower respiratory tract. It can last forever. This has a wonderful bell-shaped curve, and that's how I try to tell parents when I'm not giving them an antibiotic because there's nothing going on that I need to treat them for an antibiotic for. And that's what one of the first things I tell them. I say, the good news is we don't need an antibiotic today. The bad news is they're RSV positive. Some of the docs won't even test for RSV. They'll just tell you, well, this is an RSV-like illness, and what's the good of testing when we're not going to change anything about what we're going to do. However, my thought, and one of the other docs that I work with, their thought is kind of like my thought, in that sometimes a parent needs to know exactly. If my baby's got RSV, okay, because I can go look that up on Dr. Google, okay? Not always a good thing, but it will confirm that antibiotics are not necessary. Also, if the kids are in daycare, having a positive RSV diagnosis keeps them from daycare. And there's a lot of the daycares have guidelines as to when they can come back. So, if they're staying home with mom, you can look at mom and say, we can test them or not. This is what I think is going on. That all the symptoms are consistent with this. And there's not a whole lot we can do except fluids, cool mist humidifier, saline and suction. So, day 3 or 4 is usually your worst day with fever and snot, just copious amounts of just clear goo. Some of these kids will have fever, some of them won't. I've had them as young as a week old. I had a baby when I was practicing in Eastern Kentucky that came home to a foster mother because the baby was born to a drug addicted mother and the baby was having neonatal abstinence withdrawal. Yay. So you got a baby who's already got tremors and having withdrawals, and it's got this shrill cry, and then they get RSV and they are a week old. We kept this baby out of the hospital. I was on constant contact with this mom. This is back before we didn't know that we shouldn't do bronchodilators and all this other stuff and steroids, which you're not supposed to do because it doesn't help any. Because we were doing all of that. But anyway, this foster mother was very compliant, and we worked and we kept this baby out of going back to the hospital, which was, I think, a good thing. But it is the most frequent cause of hospitalizations for acute care in infants. It can be mild to severe is what we've already talked about. Sometimes this is the first wheezing episode for infancy. A lot of times kids, once they've had RSV, will continue to catch upper respiratory infections pretty easily. And it's a frustration to parents. You can have bronchiolitis and not have RSV, okay? So RSV is a particular type of bronchiolitis, but you can also, like I said, you can have a negative RSV test and still have bronchiolitis. As we already talked about, antibiotics are not going to help that, but you can have secondary infections. If you've got all that drooling, what else can you have? We've already talked about it. Ears, pneumonia. You can have RSV pneumonia, but we're going to treat those. And again, bronchiolitis, unless you've got a positive RSV test, it is a clinical diagnosis based on symptoms. Oh, and you do not have to wheeze to have RSV. Sometimes if you're listening to them, if you're auscultating them, you may have some coarse breath sounds. You won't necessarily hear crackles or wheezes, but they'll just be wet sounding, coarse. And it's hard to tell in children and infants whether that's actually just coming from where they're breathing and it's like sitting here in the back of their throat, or whether it's truly down into their lungs, because it resonates so easy. So I'm not going to go to them, but in your respiratory disorders tab, you have the AAP guidelines for bronchiolitis. You need to read those, okay? Just check those out. So as we go, more signs and symptoms. That copious runny nose, they may or may not have red, watery eyes. Most of the time, a lot of times they're going to have a secondary ear infection, maybe not initially, but as they go along, they're not going to be able to eat. They're acting as if their throat hurts, but a lot of times it's just all that drainage that they can't breathe, that suck, swallow, breathe. Again, I don't care if they're eating as long as they're drinking. As long as they're wetting diapers and they're drinking, they're going to have some tachypnea. That's another one of your good clues. If they come in and they're going, and they're doing a shallow tachypnic breathing in your office, and they got all this snot and stuff coming out of their nose, that's a pretty good indication. You're going to do, I guess we're going to get to that. I forget that. Nope. Yep. Well, you're going to make sure that you do O2 sats on these kids. We want to keep their O2 sat above 90. If it's dropping below 90, this kid may need to be hospitalized and monitored for oxygen in case they need it. So I've seen this, as kids worsen with bronchiolitis, you may have some intercostal and substernal retractions. Sometimes they're going to wheeze. You may even see nasal flaring and grunting and that prolonged expiration. If you've got kids doing that, you've got problems, okay? Nasal flaring is one of those last symptoms that you're going to see. Retractions are one of those last symptoms that you're going to see. They're in pretty sad shape if they're retracting and grunting. So again, they may or may not have a fever. I've had them both ways. I've had some kids that looked like they had just had a mild cold and it was positive for RSV, and I looked at the parent and said, "You're blessed." All right, so in your guideline, you do not administer albuterol or epinephrine unless sometimes, again, if it's been prolonged and we try an albuterol treatment in the office or at home if they've already got it and it seems to help. Sometimes just the moisturization of the airway seems to help. You're not going to administer hypertonic saline, but you're only going to do it if they're admitted. You're not going to do it at all unless that's your protocol for wherever you're at and whatever you're working, okay? Your systemic corticosteroids, so oral or shot, are not going to help any with that. You're not going to put oxygen on them unless they start falling below 90% and staying below 90%. I would have a kid that was a preemie, that was a twin, that was doing okay. If they were awake and alert, they were staying 90-91, fell asleep in the mom's arms while I was in the room with them, dropped to 86 because we were doing continuous O2 monitoring, and I went to the doc and I was like, this is what's happening when they're awake and alert. This is what's happening with their sleep. And so she said, okay, let's put them in for at least 24-hour observation and see if we can't get those O2 stats more stable. And of course, they did. But I felt safer and better the fact that I had gone to my doc and said, this is what's happening. I wasn't making the judgment call of you go to the hospital or not. If I had to have made that judgment call, I would have sent them on and let the on-call whoever provider. If I had been like a walk-in situation, I would have sent them on to and called the ED and told them that they were coming, or got a hold of whoever the on-call doc was for that practice where that kid came from, and told them what I had and let them make the decision and then document that thoroughly. Most of the time they want them to go on so they can have a little bit more thorough O2 monitoring, at least for a while. So we're not going to use antibiotics unless there's a secondary bacterial infection, and NG or IV fluids may be necessary. Sometimes they are, but most of the time they're not. So what are we going to do? I've already talked about this. Saline, suction, cool mist humidifier. We're going to prop them up to sleep. I've talked with parents about some very inventive ways, because babies, you still want them to lay on their back to sleep, but we want to prop them up somehow. Sleeping in a car seat is not a good thing, okay? You may do that, or in a swing. Because they're not in the right position. They can get all crumpled up and bent over, which can impede the airway. So we don't want to do that. So rolling up a towel or a small pillow and putting it under the mattress, actually putting blocks or books up underneath the crib on that end, so that the baby is laying flat on the mattress, but that the head of that bed is elevated up so the baby is at an angle. So there's just inventive ways. Talk to parents about how to do that. We're going to push those fluids tolerated to maintain hydration. Again, smaller, more frequent feeds may be necessary. This too shall pass. It's a pain in the butt, but it can be very serious. So it can cause death. So we want to stay on top of it. Foreign body aspiration. It happens. Kids swallow things, or they got something in their mouth and they either hit themselves or somebody hits them, or they try to talk and they suck it down. A lot of times they just swallow things into their stomach, but sometimes they suck it down into their airway. If you've got a sudden onset for a cough, or a unilateral wheeze, or diminished breath sounds, or loss of voice, this needs to be on the top of your differential as a foreign body aspiration. And the reason that name PIPA is there, Dr. Pinkley Stewart, it reminds me of a story back in the early 90s. We had a patient that come in with this cough, this little, and it was a toddler, young toddler, and just, and so treated it. And the mom calls back and she's like, it's not really getting any better. This cough is persistent, having more trouble breathing. Finally did a chest x-ray on this kid. This kid had somehow picked up a wood screw off of the floor. It had flat head on one end, but a very, very sharp point on the other end, and put it in his mouth and swallowed it, and it got wedged in the trachea, and it actually punctured through the trachea and had caused a mediastinal pneumothorax in this kid. The fact that he was still conscious and still breathing was amazing. So this was an immediate, emergent, get them in, get that out of there, and get a chest tube in, see if we can't get this kid reinflated. So that was a send out. Yep, kid is all grown now and doing well. Didn't have any further complications. But again, keep foreign body aspiration in your mind as you think about those kinds of sudden onset kinds of things. Pneumonia, we see, oh my gosh. Anytime we've seen a ton of pneumonia this year. I think it was associated with our really poor weather. We didn't have a real winter here where we are. If you've got a kid that has a cough and a fever, and it's been pretty persistent, this needs to be your number one differential. They have pneumonia until proven otherwise. And you've got your types there, your lobular, your interstitial, your bronchopneumonia, your atypical. Strep pneumoniae is one of our top organisms. Again, we have Prevnar 13 to help fight some of those strep pneumoniae infections. And you can read all that. I'm not going to read it to you. A lot of times interstitial pneumonia has usually been caused by a virus, but it can set the stage for bacterial pneumonia. So when I said you may have a RSV pneumonia, that's true. And that's viral, but that can set the stage for bacterial pneumonia. So we're always going to treat that with an antibiotic. Bronchopneumonia here is defined as a bacterial infection with multiple areas of one or more pulmonary lobules. Now, I have a doc that calls it bronchopneumonia. If you've got some streaking on X-ray, and a lot of times our docs will read it as normal, but you see that streaking that's going along, and they present with this cough, and sometimes they have fever, sometimes they won't, and they just cough and nothing is helping it. He'll call that a bronchopneumonia. A lot of times, any of our school-age kids, most pneumonias are usually caused by mycoplasma pneumoniae. A lot of times we call this walking pneumonia, especially in adults. And I'll say it atypical, and I'll say mycoplasm, and then I say, a lot of people call it walking pneumonia. Then the parent goes, oh, okay. They identify that as not very severe. So, because a lot of times parents, when you talk about pneumonia, they think about their grandparents or their parents who've had a pneumonia have been really, really, really sick. Some of these kids aren't really, really sick. Some of them are really bad sick, but some of them are not really bad sick. So sometimes you'll even see wheezing in these, and a previous non-wheezer with this. So if you're doing labs, if you do a CBC, if it's bacterial, it's usually going to be elevated. Viral is going to be either normal, maybe mildly elevated, and your atypical pneumonias are usually normal. Your chest radiographs, you're going to see a consolidation. Anytime you see a part of the heart that is obscured by stuff, then you've got a pneumonia. Or if it streaks out into the lungs, especially on the lateral view. And then we see this term a lot, interstitial infiltrates. So, okay, you've got a type of pneumonia, and parents just go, oh, it's like, it's okay. We're gonna fix this. It's pretty easy. So if you got a bacterial pneumonia, amoxicillin or amoxiclav or Augmentin is really your drug of choice. Anything that's going to work on your strep pneumoniae, which is your most common organism for that. A lot of times with viral, even though we're going to treat, it's usually mostly supportive care. But with your atypicals, your macrolides are going to be your common. And a lot of you already know that with technically with bronchitis, you're just not supposed to treat it with anything. It's supposed to run its course because it's viral. But a lot of times it's actually an atypical or this mycoplasma pneumoniae. So what's going to touch it? Your azith, your chlorith, your erythromycin, so your macrolides. So these kids usually get a Z-Pack from us or a azithromycin. So we've talked about pertussis, cough, azith. We talk about pneumonia, atypical with this cough, azith. So do you get where I'm going with that? So we kind of reserve azith for those kinds of things. As a sidebar, you may be taught that azithromycin is an okay drug of choice for strep. There's a lot of treatment failure and a lot of resistance with azith. So if they're not allergic to penicillin or cephalosporin, go with that long before you ever go with azithromycin. And if you're going to do that with kids, because there's nothing else, then it's at 12 mg per kg per day for 5 days. And then you may want to even follow up with the throat culture to make sure that they clear. So that's just a sidebar. Okay, that is done. I am done for respiratory. And Dr. Blankenship's going to come over here and stop us. Again, if you have questions, concerns, comments about the respiratory, send all of those to Dr. Blankenship and I will answer them and we will get them posted for you. Hope everybody's doing well. Bye.